All right, it is 1 o'clock, so if you're all ready, I think we'll go ahead and get started. Good afternoon, everyone. Thanks for joining us for another Facebook Live with Side Effects Public Media. We have been collecting questions from community members and using those questions to drive our reporting and our direction for some of these Facebook Lives. We're launching a new series of these, looking at some of the changes that have occurred because of COVID-19. Today, we're looking at the way many people have lost their jobs because of the pandemic, and with their jobs, they've lost their employer-provided health insurance. We're taking a look at the problem as a whole and talking about what people can do if they find themselves unemployed and uninsured at this time. To start out with, I'm Brittany Howell. I'm the Community Engagement Specialist for Side Effects, and I'm joined today by three guests. I'm going to go around, say everybody's names. When you hear your name, say hello. First guest is Mark Fairchild, the Director of Public Policy at Covering Kids and Families of Indiana. Welcome, Mark.
Happy to be here.
We also have Calvin Roberson. He is the Vice President of Planning and Program Development at the Indiana Minority Health Coalition. Thanks for being here, Calvin.
Thank you for inviting us and being at the table. We're looking forward to the conversation.
Wonderful. We also have Adam Mueller, Director of Advocacy at Indiana Legal Services. Hi, Adam.
Hello.
Thank you all so much for being here. And with that, I think we're ready to get started. We welcome all of you in the audience to contribute your own questions by leaving a comment beneath this video. We'll do our best to get to those questions over the course of the hour. But for now, we're going to start with sort of the big picture. What do we know about the number of people who have lost their jobs or currently don't have jobs in Indiana and therefore have lost their insurance?
Right, and I can lead that one off. So we're looking at really the high point of the pandemic and the job loss was back in April, where we broached over about 560,000 Hoosiers losing employment. We have recovered a little bit from then, so we're under 400,000 now. Hopefully the next round of numbers comes out will be close to 300,000. So we've recovered dramatically, but that still is going to leave over 10% of Hoosiers without a job. And related to that, of course, the insurance that goes with that, the impact's not just them, but their family members too. So every time we see an unemployed Hoosier, at least half of that amount had employer-sponsored coverage. And then if we look at multiplying that by the average family size or so, even at 300,000 Hoosiers unemployed, we could be facing upwards of 1 million Hoosiers that don't have health coverage through an employer any longer.
And for the kids piece particularly, am I right in thinking that with schools kind of in flux right now, kids are sort of without one of those other mechanisms for catching health problems and addressing health problems if they don't have insurance?
Right. Traditionally, schools are a great set of eyes on our kids for health problems and everything else that's going on in their life, social supports, behavioral health, and other needs are there. And not only that, but a lot of schools have school-based health clinics and other services, and sometimes function as a de facto medical home for that child, or at least the pipeline of parents to encourage them to see a doctor and to get back involved and maybe even seek healthcare coverage. So we don't have that set of eyes that usually naturally happens there. Schools are starting to come back into session, but we also know those schools and the school nurses have one very big issue on their plates, so they're not able to drill down necessarily on those individual needs for kids like they prefer to be able to do.
And Brittany, I would just add too, I think the other component to the employment piece is just the state budget. A lot of Hoosiers who are working, they contribute to the state budget. And because of some of the forecasts, some of our programs are being challenged because there has to be a reduction in support. And so when we are looking at this whole employment issue, we're also looking at the tax base not being able to contribute to state-supported programs and services who are reaching the most needy population. So when we're talking about employment, it's not just that people are working, it's also about people's ability to contribute in supporting the system that we have. And so I think the last time I checked that we were facing a 15% reduction in the state budget overall. And so resources are now having to be supplanted in other ways to help support some of the great work that's being done. And the reality is we may not be able to find some of that support elsewhere. And so when we're talking about disparate populations, they're hurt at a greater severity as a result of what's going on in this whole employment environment.
Calvin, could you talk about some of the specific programs you have in mind when you mentioned that budget shortfall piece?
So I know FSSA, a lot of their programs have been asked to reduce their budget. So things, I sit on a couple of different boards. So some of the things dealing with seniors and the programs and services that they are receiving in home-based care, or some of the resources that would help to feed or get food to them, those types of things, they're being reduced. And so those agencies have to supplement those services that will get to them with other money, or they're going to just have to reduce how much they're able to give to individuals who are currently receiving services. But those will be, examples, right off the top of my head, where people are being impacted directly for services.
Thank you. To sort of localize the issue at hand, in general, what are the challenges that a person might face if they don't have health insurance? And are there any specific challenges caused or exacerbated by the current pandemic?
Sure, and I can kick that one off. I mean, health coverage, it's one of those tricky things because a lot of people see it as something that's kind of future looking, like I'll use it if I need it, if I have to go to the hospital, if I get really sick. But it also counts for things like preventative care, childhood vaccinations, all those well checks that we're supposed to do so we don't get to the point of having to go to the hospital or do further things. And of course, we're in the middle of a public health emergency where we need the healthiest Hoosiers we can possibly have. Right. So, but now we've got a new sector of burdens that have been thrust upon that make it harder. That one, a lot of these folks that we've talked about that are newly uninsured, they don't know these programs. They don't know what's out there for them or what's available to them. They don't have an assumption that there is something available to them. And they've got dozens of other things on their plate too: food insecurity, loss of home, that in their mind might come first before we look at healthcare coverage. So it's a terrible storm that, as much as we want to get them healthy and get them insured right now, they've got so many other things on their plate. These health coverage systems are completely new to them. They don't have the innate expertise to understand it. Frankly, most Hoosiers don't know all the different terminology and jargon and everything else, let alone where to look to find something that's going to be fit for them or how to fill out all those applications. It's a mass amount of burdens. And then, of course, a big thing that's come out of what we've seen with COVID and what we've seen with a lot of things is issues of disparity, where all of those things are amplified when we look at minority populations and other disparate groups. This kind of turns into that argument of the one more hill, one more burden. A group approaches this crisis already having 6, 7, 8, 9, a dozen points of disparity, other things that are barriers that we don't even realize are there for them. And then we add all of these new barriers. And it gets to that point where it's just too much to be able to meaningfully engage, figure out all these processes and go through it when you're already coming into this crisis at a point of exhaustion.
One other thing I think maybe worth pointing out in terms of the folks that are uninsured right now or not is that if there's a possibility that later on down the line they may be faced with some significant medical debt burden, and that could be problematic, especially as folks are getting back to work, getting back into the swing of things, having sometimes $10, $20, $30,000 of debt and not knowing how to work with the hospital to negotiate that and whatnot. So that's another issue that we're going to be looking at as folks do sort of start returning back to work.
And just as another thought too is access is an issue when you don't have insurance, and so if you're sick and you're trying to get well, being able to go to someone so that you can get well or identify what the issue becomes critically important. So when you don't have insurance, it doesn't allow you to do that. The other thing is you have to pay out of pocket. And so we're asking folks who already have minimal resources to pay high extreme rates for services that in any other context is shared. So we're asking folks to take an individual burden. And the whole ideology with health insurance is to use this risk utility approach where you're minimizing the risk by pooling a collective resources of both those who are well and who are not well. And so unfortunately, those who would benefit most of the program would not be able to afford it in and of themselves. And so health insurance of being able to pool helps to really minimize their financial burden. And coupled with that, I mean, in our state, specifically, healthcare expenditures or debt has contributed to foreclosure and having being the number one reason why folks have entered into foreclosure as homeowners or just housing in general. The inability to meet the healthcare expenditures has contributed to folks having to make decisions that we really don't want people to make if they don't have to. But if I'm going to live somewhere versus I'm going to pay my healthcare, people are going to try to do the healthcare, but sometimes it doesn't work out that way, and folks lose their home because you can't work if you're not healthy. You can't function and just go through life when you are at a state where you're sick and ill. And so I think that's really important. And health insurance affords people the opportunity to be able to get well or find out what needs to be treated so they can get well.
One other thing I think maybe goes back to a point that Mark was making earlier is that signing up for health insurance can be really tricky if you're doing it on your own. But folks are afraid to go to hospitals right now and they're afraid to go to clinics, and oftentimes that's the point of contact for getting signed up for programs. And so if you're not going to those appointments, if you're not going to the hospital, not going to your local healthcare center where they'll have somebody that's there to help you get signed up, you're not going to be able to access the system.
Right, and that's really important because, and Calvin's absolutely right. I mean, healthcare coverage is expensive, and if you're not getting employer-sponsored coverage and you're now seeing the bill for the first time, what it looks like when your employer's not kicking in 60, 70% of the premium cost, those are large numbers. But they're also not encountering the people that can introduce them to programs like the Healthy Indiana Plan, the Children's Health Insurance Program, that can get you coverage that's going to be at very, very low cost, or right now with a lot of the premiums and cost sharing and co-payments frozen, potentially no cost. So they're seeing that big sticker price. They don't know there's another option. It's an easy thing to back away from.
I think, Mark, to your point, and then also Adam, part of what we had seen in our Healthy Indiana Plan study is that when people are encountering navigators, sometimes the content of what's communicated is not consistent throughout. And so people are not always being able to take advantage because it's not being explicated to them. And so I think, part of one of the systemic things that could potentially happen is that I hate to say, but sometimes you have to develop a script for communication to make sure that all the salient points are covered so people can get as close to the same information as possible. So it's less subjectivity and more objectivity in what's communicated. And so the application process, I think, has been one of those things that has been a challenge for some segments of the population. And I think we can do better. But I think overall, HIP in general has been a greater help to the state of Indiana. And so we're glad for it.
This is a really good segue into talking about the fact that in this conversation, we're sort of encompassing a bunch of different kinds of insurance. We're talking about employer provided health insurance and also state provided health insurance. Really quick, just to kind of lay the groundwork, are there any groups or demographics that in general have less access to employer provided health insurance? I mean, we know that not all jobs provide it.
Right, and it's tough to talk about that in broad terms, but we know typically lower wage workers are less likely to have that option provided, especially if you're with a small employer. There's certain rules that don't apply if you're with a smaller business about what you have to provide for your employees. But there's a broader question there too of an employer can offer coverage, but it might not be affordable to you. So you're declining that and looking elsewhere for that. And of course, we have, with the current state of unemployment too, we have sectors that were disproportionately impacted by loss of coverage by more of their sector going under. We know the service and hospitality industry dropped about 40% because it's a high contact area. You can't really maintain those jobs easily in the current situation. And that's a sector that has a very high amount of minority and new immigrant population working in it. So even if they had health coverage offered, that option's off the table for a massive amount of folks. And if their skill set is in those industries, it's not easy for them to just transfer someplace else and get that either. So there's all kinds of stuff interplaying there with the employer-sponsored coverage that maybe they weren't offered in the first place. If they were, it may not have been comprehensive or affordable or both. And now that some of those same sectors are the ones likely to be laid off too.
One other program we haven't mentioned yet so far is just going onto the marketplace for insurance for folks. And so you've got, you know, your employer-sponsored coverage, and you've got your various state programs, but you can also qualify for, I believe, Mark or Calvin, fact check me on this, I believe you can qualify for special enrollment period for job loss, which would allow you to enroll into the marketplace, even though it's not during the traditional open enrollment period.
Correct. That is true, and it's actually not even got the same rules on it would have before. So usually the marketplace is something, yes, for job loss, you can apply for what's called the special enrollment period. So it's a step you have to take, go to healthcare.gov and walk through those steps. But because the country's under a public health emergency, you've got a lot more freedom with that. So even if you lost your job a while ago and you think you missed your shot, you probably didn't, because it'll go up to 60 days past the end of the public health emergency. So even if you lost it back in January, you can probably still apply for coverage. And we always caution people, when you look at the marketplace and you hear about high costs on there, go through the entire application process, because if you're unemployed and your income drops substantially, you probably have a very large subsidy coming in there to help you out. So what looks like a $400 plan might actually be $80 to $100 out of your pocket, or it can be reduced down to zero.
And I would just highlight too, you had asked about target populations that may be impacted. I did want to bring immigrant populations to the fore, because many of them are challenged in a multiplicity of ways. Some, as we know, are undocumented, and so they're not eligible for anything. And so when we're talking about this crisis, they are forced to work even when they're in conditions where they may have been exposed or they may be sick, because that's the only way that they are going to be able to meet and pay their bills. They don't get a stimulus. It's just that they don't qualify. And so they have to generate the resources to continue to thrive and survive. But the other group, even within the immigrant, are folks like the refugees who are legally, they can be here, but because they really don't know how to navigate our system, it becomes more challenging, particularly in this environment that's really virtually based. And a large segments of disparate population and poverty population, they don't utilize technology the way that we are requiring folks to do. We're asking everyone to go to websites. We're asking them to make phone calls. We're asking them to participate in Zooms and GoToMeetings and WebEx and things of that nature. And the proficiency to utilize these platforms is just not something they're familiar with. And so we're having groups of people that we're having to orient to technology just so they can access service. Our seniors, many of our seniors, they're not familiar with technology, and some of them really don't want to use it. But because of our current environment, particularly with COVID, they're being forced to try to understand and to utilize it. And so when we talk about different targeted population who is being impacted about where we are, there's quite a few where it's just a greater burden to try to access what is available, let alone when it's not made available to you.
Yeah, so many different pieces interplaying and just exacerbating existing problems. We've mentioned HIP a couple of times, and I'd like to talk more about that. But before we get into the various access and the problems with maybe like getting and keeping your HIP, could we have a quick crash course on what HIP is for people who might not know?
Yeah, I'd be happy to go through the basics. And one thing I always caution before I go through any program, of course, too, is if you're somebody that's looking for coverage and don't know what's available to you, or if we're talking about even makes any sense to you, there are lots of groups to help out with you, help you out with some of those details. I represent a navigator group, which is navigators or simply somebody you can sit down with, or in these days, talk virtually with and figure out what your options are and what you might be eligible for. So don't try to do an eligibility check based on anything I say. But the Healthy Indiana Plan, in a nutshell, it's a program that's been around actually for a long while, before the Affordable Care Act and all of that stuff, going way back 2007. I was actually part of a group that was helping pilot out a few pieces of it. And it's meant for adults that don't have a health coverage option. So maybe you're not low enough that you're in the Medicaid ranks, but you don't have substantial income to just go out and buy a policy for yourself either. The cutoff is around 138% of the federal poverty level. That's based on all kinds of other variables, so we won't get into that here. But it's a very comprehensive health coverage program. Um, Typically, it would recover, or it would count that you need to make some small payments into what's called a power account. Think of that kind of sort of like your premium, it's amount you have to put in. But you get very comprehensive benefits, very low copays, and actually you can buy up to, if you're being involved in that power account and you're making those contributions, a version of the Healthy Indiana plan called HIP Plus that adds things like dental and vision, and removes most of the co-payments. So very good, very comprehensive coverage. And right now, if you're an adult that's unemployed, there's a really good chance that you qualify for that. So it's something that you can definitely, if you have the technology access, Google it up or contact really any of the groups on the call today. Would be happy to link you up with some of that program or a navigator that can help walk you through that. But it's a great program, helps hundreds of thousands of Hoosiers, and it's seen a lot of growth over the last few months. During the pandemic, it spiked up about 25%. So which still doesn't cover all of the people who have lost coverage by any stretch, but it has seen a nice bump up. And right now, if you get on that program, they're freezing the power account contributions, that small monthly amount you'd have to make, the co-payments, and the ability to terminate you off of that coverage based on some of the fine things that you have to do and stay on track on. So if you're on it already, it's hard to lose that coverage. You don't have to worry about stuff that you might have missed in the mail or making a small payment right now. We realize that there's a lot of burdens on people. So that's all been frozen. And for new folks getting on, again, they're not going to have to worry about some of those details and chasing a little bit of the paperwork that they would have had before. Some of that's been lessened as well. So it's a really great program. Anybody who's unemployed, that's looking what their option would be, I'd strongly suggest starting there and seeing if you might qualify for a HIP plan.
Just to follow up on what Mark said, so Mark pointed out that if you have questions and you want to figure out about eligibility, go to them. Folks come to us when things don't work. So when there are issues and people lose coverage, we help them get coverage back or sort of navigate the system with the administration and the bureaucracy and that sort of thing. I think it's really worth pointing out that the data that's out there, and I think Mark or Calvin can chime in on this as well, has shown that HIP has been a really important vehicle for people to really stay covered or get covered during this crisis. The numbers indicate that Indiana has seen more folks go on to HIP is a Medicaid expansion program at this point in time, going on to into our program than in some of the other states. We've had 18% increases from February to May, and from what we can tell, it's not clear exactly what happened. And those increases are significantly higher than some of the other states out there that are not seeing as much increases. But from what we can tell, one of the key issues here is that those premiums have been frozen and waived for our folks. So often the reasons they came to us for issues is because they couldn't figure out how to make a payment. Their payment got lost in the system. Sometimes just $1, but that was the barrier for you to get and keep coverage. So that has been huge. We haven't had people contacting us during this time to say, hey, what's going on, and I can't figure out how to navigate the system because of my premiums, that sort of thing. I believe that in the 2017 report, there was 40,000 people that never signed up for HIP that could have because of the premium issue. So that has been big. One of the other issues that we've also been sort of talking a little bit about, and Calvin's group has done has funded some reporting on this, is this idea that certain groups of folks, particularly Black and brown folks, have more of a disparate impact when it comes to whether or not they're able to keep that HIP Plus program that Mark mentioned that's got really great coverage, or just stay on HIP in general. And that premium has been an issue there. And I think that when you look at, those things are problematic in general, but then when you magnify them in this pandemic and say, well, we're also seeing a significant disparate impact in terms of the disease burden of COVID on these same communities, that it's hard not to sort of link the two and say that this is something we ought to really be concerned about.
I think this is a really good place to pause and talk a little bit about that report that the IMHC funded. Calvin, would you mind taking us through a little bit about that report that came out, I believe, last summer?
Sure, yes. IMHC funded a study in partnership with the Indiana University, their School of Religious Studies, as well as the Shepherd Community Center and First Baptist Church, to explore what the role of faith communities could be in promoting the Healthy Indiana plan, and also to find out what are some issues and challenges that community members may be facing within their context in either accessing the Healthy Indiana plan or utilizing the Healthy Indiana plan. It was a qualitative study, so it wasn't designed to capture things from large groups of people, but to hear stories from a variety of different groups of individuals which those faith communities serve, to find out what their experience has been along the continuum of the Healthy Indiana plan. And in doing so, we found out several things. One, in the application process, as I stated earlier, is multiple messaging. Some people would get certain information, others would not. Some of that was attributed to personality conflicts. Others is knowledge of those who were providing the service, as well as the knowledge of those who are going through the application process. And so making sure that there is standardized messaging in the application process is important. But also, we found that depending upon the type of work people had, could predispose them to be kicked off. So folks who were construction workers would talk about how every year, a couple of times a year, they would get booted off because they made too much, but then they would have to reapply for the same insurance when it ended. And so there was this cycle that was going on where people were getting booted off, reapplying, coming back on. And so part of the recommendation is let's, instead of looking at it from a month to month or quarter, let's look at it from the entire year and base decisions on health insurance coverage based upon a year as opposed to periods of time within a year. That would actually help troubleshoot some of this on and off patterns of coverage and not coverage for folks who really need it. So that would be an example. Another person just shared about utilizing HIP and being able to go to the doctor's office for services, and being told that during the process, things just didn't get processed well. Some got mixed up in the office. You were booted off of coverage. So they're walking in thinking, hey, they had it because they had this letter that says they have the coverage. But then when they go into the office to actually get service, they're told, we can't see you because you're not covered. And then they call someone, and depending upon who they talk to, they may get multiple different variations of the story. And so folks who are in those predicaments, they get frustrated and they don't want to talk to 5, 6 different individuals. So they opt not to talk to anyone at all and do the traditional approach, which is the emergency room. And so the whole design of HIP is to help get people from the emergency room model to a medical home model by providing the infrastructure support that allows people to do that. But when there's fragmentation within the system, it's hard to do that. Now, overwhelming, this is not the majority of cases, but it's significant enough to warrant some attention as to possible fixes within the continuum that can be had. And I won't take up any more. Love to get feedback from the other two panelists, but just want to highlight that the report would look at the application process, utilization process, the treatment process, and it provides a litany of recommendations that's coming from community members that participated on how the system can be fixed. There was a number of community forums. I think Adam may have participated in one of them where we had FSSA come. We were there, they were there, talking about what was going on with HIP, also getting participation from the audience about what could be changed. I was amazed. One lady told a story about a senior transitioning from HIP to Medicare, and how she wanted the client wanted to keep HIP because it was better than Medicare for their context. The other thing is other states have an automatic system where people can transition smoothly from Medicaid expansion to Medicare, and we don't have that. And so those types of nuances are reflected in the study to help build a better system. Overall, the system is good, but the system can be better.
I just want to point out something that came out of that report that I think is really worth repeating. This is one of the sentences in there. With the exception of finances, more is expected of HIP applicants and members compared to Hoosiers with employer-sponsored coverage, federal marketplace, Medicare, or other Medicaid plans. More is expected in documenting eligibility. More is expected in selecting coverage plans without clear benefit comparisons, and more is expected in retaining insurance. And I think it's really worth noting that removing that one gap of having to do the premiums has had such a significant impact in terms of how the rates of folks being able to apply and keep insurance. The other piece I'll say is that the study that Calvin's referencing also sits well as a qualitative study to the quantitative study that was produced by the state in analyzing, that sort of talked more about numbers and the numbers of folks that were losing coverage because of certain issues and complexities. And the report that from the Calvin references sort of puts a face to those numbers in a really good way.
Right, and
a video to it too. I just want to say there's a video, so if people don't want to read the elongated version of the paper, there is a video that people can actually access that gives an overview of the report and the people who told their stories.
Yeah, and it was a wonderful report, and I know I was able to participate at a couple of the meetings as well with that. And it's great sometimes to get away from the numbers and look at that qualitative information, because it really gives you perspective. Because some of the state reports, we got very good numbers on a lot of things where people were falling between the cracks. And it's easy to get in the boat where you say, well, people should know that, and we've got that in the brochure, and we've got the information out there for them to find. But when you really get the stories of somebody who was maybe on HIP for 2 years and still didn't know the information about how to make sure they were on Plus and what the benefits of Plus are, that's not failure of that individual. If at that point 2 years worth of correspondence didn't create that messaging to them, we've really failed something. But to Adam's point, when we talk about the power account payments and how that's a common obstacle too, we don't need to just look at and say, well, what are the things we need to communicate better? But what are the points of communication that we really shouldn't have in the first place? What are obstacles that we shouldn't have to explain to them because maybe we shouldn't have those obstacles? Do they really have any great effect? So the example of the power account payments, for those listening that don't know, those can be $2, $5, the very minimal monthly payment, enough that even if you don't have that, and some people $5 to $10 a month is still money that they don't have, but they might have resources that can pay it. A lot of community churches have programs where they'll pay those payments and do that. But if you don't know those resources, don't have those resources, if you don't realize it's a bad idea to just throw cash into the envelope and send it in because maybe you don't have a checking account, or you put the church's name on the check instead of the person that it's going to pay, there's so many different things that can get in the way of that. And that $5, of course, doesn't pay for the state's time in processing it or moving it along or anything. It's based on the concept that thinking that people have to pay something in to value a service. Now, it's one of those things that suddenly clicked to me too. I'm like, do you realize how much work it is to go through the application process and figure it out? And even if you go through a navigator group or anything, finding one of them, working with them, driving to an appointment, all the hoops and hurdles you have to jump through. If that's not already buy-in, I really don't know what is. I don't think an additional $5 is something that's really necessary when they've had to go through all the hoops and hurdles, just learning about these programs' existence and then applying for it and keeping the coverage and filling out all the other forms to stay on it. We've got buy-in. So is it really just another obstacle we're creating for no productive reason at that point? And a lot of when we say HIP is up 25%, we do need to look at that number and say, is it up a true 25%, or are the people that would have gotten bumped off because they missed a payment or they missed some kind of paperwork to stay on HIP, are those people that just, since they didn't get knocked off, offset and make the number look a little bit better than it was?
It definitely
And
begs.
Mark,
Oh,
I
go
was
ahead,
going to say,
Alvin.
Mark, and to your point, you had highlighted communication. One of the things that did come out of the study was that it is a two-way communication. And so there's things that's happening with the system, but one of the things that did come out was that a lot of folks are transitory, and they're going from house to house, home to home, place to place. And the way that the system is designed is that you have a point of reference in terms of an address. And so if your address moves a lot, if communication is being sent to you from something that's no longer existing or you're no longer there, some things are missed that way. And so part of what also came out is that there is a need for those who are receiving HIP to really communicate in real time about where they are. And if they know that they are going to be transitory, is there a friend, is there a family member who doesn't move, that the information can get sent to, that can contact them, so that those services can be maintained. And so I do want to make it clear that we look at this as a two-way street, that there is things that the systems can do, but there's also things that individuals can do to make sure that coverage stay intact and communication becomes critically important for that very reason. And also having someone adding on with them who can operate on their behalf, even if they're not there, whether it's because there's a disability, the mental illness, or something else that's in place that may contribute, whether or not they can survive. They may have a chronic health condition. They may be in the hospital for periods of time, but also making sure those things are in place. So there won't be a lapse in coverage. That's something that an individual can really take control of and own and really address in this health insurance process as well.
Just wanted to say on Calvin's point about the mail, luckily we're not having any mail problems these days. Everything seems to be working just fine. With regard to the transitory issue as well, the fact that we have an eviction moratorium that just ended, but for several months prevented folks from being evicted. It's speculation without seeing data, but it wouldn't be surprising if that's contributed to folks being able to sit down and go through the eligibility process and get and maintain health insurance, maybe across the board, because they are in one place. And if we see sort of a significant disruption in coverage for some reason, that could be related to the eviction moratorium ending this week.
And there are some populations that are going to be naturally moving between environments quite a bit too. So when we look at people that are maybe coming out of addiction treatment, Well, they might go into 3 or 4 different settings before they're back to their home, even over the course of a year, between different kinds of environments and outpatient settings and inpatient and other things there. And these are folks that need very regular care. They need their therapy, they need their prescriptions. That's a very dangerous system to risk disrupting that. And then if we have people that were incarcerated and are moving from that system to maybe some kind of a halfway environment to some kind of temporary living until they can get back to the place where they can have their own living environment that they're able to purchase or rent or get involved in. And those are both large groups that need additional support in order to stay stable and to stay involved and get on a positive track and be in a good place. And both of them are at such high risk. Again, just like everything else, anybody who's part of a disparate group, now it's made worse by COVID too, because the resources are that much thinner. But those are two great examples, ones that they might naturally have multiple addressers over the course of a year, and they're probably going to be in that pool that qualifies for the Healthy Indiana plan. If mail is the principal correspondence, even if they are watching it closely, the odds that one important documentation that wants them to put in their income so they can keep their coverage, it's easy to miss one envelope at an address you were at 6 months ago.
Going back really quickly to talking about that, those barriers to getting and keeping HIP, particularly with the power account payment, the things that have been temporarily like stayed or deferred during this public health crisis, knowing that they have been stayed or deferred kind of begs the question, if the state's able to waive those requirements now, what do we expect is going to happen when those requirements come back after the public health emergency? And at a more philosophical level, why should they?
Yeah, I can start that one. You know, and it is a very important question to look at. We're hoping right now the state's actually doing some analysis and saying, is this actually working better not having them and not having to chase those payments, the amount of bureaucracy involved and the amount of staff time involved in being able to track down and link up or move people between HIP Basic and HIP Plus and all that for the $5 or less a month, maybe that their payment would have been. So hopefully they're tracking that and saying, let's reevaluate the experiment. And now when the public health emergency ends and when these provisions are no longer placed to guard it, there's a lot of concern that if we've been bad communicating it in the past, are we going to be better communicating it now? Because we're going to need to really step up the game. We're going to have people that are still fairly new to these systems that have no idea because they never had to pay it and weren't introduced to it. Then we have other folks that are still recovering. The economic recovery is not going to necessarily end just because we magically say we're outside the public health emergency. And people that were hit hard are going to have a harder recovery arc. People that were already coming from a very difficult position in life are going to have a longer time to recover from that. So if a strategy isn't put in place to be careful about that, we could see, you know, potentially a large cliff that people are going to hit and a large pool of coverage loss as a result. And we really hope, and I'm sure they are, that the state is thinking about that and looking at what they can do and how they can be very responsible about what that's going to look like. But it's going to be a very difficult transition to do well when we know we already have so many communication struggles.
Yeah, the only thing I would say to the question posed is that when HIP was created, the ideology is that there would be some level of personal responsibility and accountability, and they wanted everyone to have skin in the game. And so my understanding of the power accounts of the whole purpose of having premiums is for people to be invested in their health and well-being. And I'm not sure that when the public health emergency passes that ideology is going to shift, or has it been challenged to the extent where people have demonstrated, you know what, we are going to be responsible and accountable even though we are not paying into it. I think what COVID is allowing us to see is if people are engaging in the same practices of having it suspended as they would when they were paying it, because that would then refute the argument that people needed to have a skin in the game to take advantage or be good stewards of this health insurance opportunity. And so I think I just wanted to put that on the table because I do understand that that was the original premise, and I'm not sure that that premise is going to go away. And I think also in lieu of the deficit that we have in our budget, unless revenues increase, that skin in the game, I think, maybe maintain also as a way to supplement some of the resources that are lacking because of the loss.
I think one thing that I should mention here is that the premiums we're talking about are features of permission that the state got from the feds to do some things that aren't traditionally in a Medicaid expansion program. So when you think of HIP, you're actually talking about two things. You're talking about the expansion of Medicaid, and then layered on top of that is something called an 1115 waiver that allows the state to do some experiments to try to do certain things that would allow for meeting the objectives of the Medicaid Act. We have filed litigation on behalf of 4 HIP members that have challenged, amongst other things, the premiums as well as the work requirements to say that they don't do anything to further the aims of the Medicaid Act, which is really to increase coverage. That case, our case is stayed right now for the public health emergency, but a different iteration of that case is going to be in front of the U.S. Supreme Court called Gresham v. Azar, and that's the case out of Arkansas. So part of this this is sort of going to be tying into it. We've made claims that some of these features are not even legal. So we'll see sort of how that plays out and how that plays into the mix of what the future looks like.
I'd like to go ahead and switch really quickly to the practicalities that we wanted to talk about of applying for insurance and what insurance options exist. Let's just say that I, Brittany Howell, lost my job yesterday. I didn't. I'm clearly here, but for argument's sake, lost my job, woke up today and thought I need to apply for insurance. What's the first thing I should do?
Okay, so yeah, there's a lot of different starting points is the tough thing. So I'll start with what you shouldn't do, which is just Google Health and Coverage Indiana or Health Insurance Indiana and go through the pile of about 30 sponsored ads that you're going to see. I caution that simply because there's so many products out there, and the average user, really myself before having this position included in that, doesn't know a lot of the details of co-payments and premiums and co-insurance and out-of-pocket maxes and all those fun terms there. So really it is best if you lost your job today, a couple of things you can do. I'm a firm advocate of reaching out to a navigator group for one thing, because they can assess and say, let me get some information from you, lay out all the possible options and help you apply for those things. It's always better to go with somebody that's already in the know that has those resources available. Now, the state of Indiana does have sites you can go onto to start with too. So if you wanted to go ahead and look up, make sure you're going through a state agency, so you're on the right portal. There's a lot of lookalikes out there. So there's things that will look a lot like healthcare.gov, which is where the marketplace is, where you can get some of those subsidized plans. And when I say lookalike, I mean, there'll be Obamacare.com and all kinds of things like that are really meant to be predatory. So you've got to take a lot of care when you're researching. But then going through the state sites, FSSA, so that's the Indiana Family and Social Services Administration, has a benefits portal where you can apply for health coverage, which would be for the Healthy Indiana plan. But you've also got options, the Children's Health Insurance Plan. So if you have kids, where you can make sure you get coverage laid out for them as well. Medicaid, it's a one-stop shop for applying. And you can also look at programs like food assistance programs at the same time. So it's a good place if you think you're savvy enough to charge in and see what you can find out. And then at least, if that you hit a wall, that you have other groups you can go to get more services and supports around you. It's hard to just look at raw numbers and say, oh, I know exactly what I qualify for and what I should be applying for. The good thing is if you go to healthcare.gov, so you're looking at those marketplace plans and you answer some of the questions and it says, hey, your income suggests maybe you should go ahead and check out with your state and see if there's a Medicaid program or something like Healthy Indiana plan available to you. It'll queue that up for you as well to say, hey, maybe you need to be looking over here. And if you don't qualify on the state programs, you can go look at then healthcare.gov instead. I definitely, again, recommend if possible, looking up Health Insurance Navigator, the Indiana Department of Insurance on their website. You can find them statewide. Odds are really good that we're probably in your area because we're statewide and we do virtual appointments. There's other groups, certainly. A lot of hospitals have health coverage navigators. So if you show up at the hospital and don't have coverage, they might be able to help you out. Community action programs have them. Community health centers tend to have them. So they're everywhere. So you just got to know that keyword to look for, that you need a health coverage navigator to work through all the things that not just you, but your other impacted family members might qualify for, because it's a lot, and it's more than I can expect anybody to figure out in just a day of shopping around on the internet.
And just to be clear, is there a cost associated with accessing a healthcare navigator?
No, and really, if you've got anybody that wants to charge you for services of getting you linked up with health insurance, you would probably pretty swiftly want to hang up that phone or stop that chat conversation. It's free resources, and really even folks that are brokers or agents for insurance shouldn't be charging you for the service of linking you up with coverage. But navigators are completely free. There's not a place in the state where you can't have one available to you, and a lot of other groups like ourselves are doing virtual appointments, so it can be touch free. If you're a person that likes to have face-to-face help just to have that connection and understand things better, there's precautions, of course, that can be taken right now to make sure that happens as well. But there's definitely going to be a resource for everybody if you look for a navigator, and they can at least get you pointed in the right direction. Even if you want to say, I want to take it from here, they can at least get you started on the path to having coverage again.
We just got an audience question, and I think I understand what they're trying to ask. They're asking basically, like, if I just lost my job, but I'm pretty confident that I'm going to have another job lined up in a couple of weeks, should I apply for HIP in the intervening time, or should I just wait it out?
Well, I'll always say that waiting it out is the hopeful thing to do, but there's of course no guarantee. And remember, when you start a job, coverage usually doesn't kick in right away. You'll be very, very fortunate if you're waiting less than 30 days. It's usually 90 days or more before that kicks in. Now, she might want to check in and say, well, when does my employer-sponsored coverage officially end? Some employers push out that gap a little bit, so coverage might be available for a little while. There is a program called COBRA that your employer sometimes will continue paying a portion of their share of your coverage. And it might be an affordable option so you can stay on the same coverage until you get more. But I'd usually err on the side of go ahead and at least start investigating those state programs and looking at the qualifiers there. There's nothing wrong with having two options ready to go. And if your employer offers COBRA, but maybe they don't kick in their part, we've had a lot of people say, well, wow, I was paying $200 a month towards my employer-sponsored coverage before, but when my employer stops paying a share of it, now the cost of that plan went up to $600 a month, and there is no way on earth I can pay that while I'm unemployed, right? So investigate, check with your current employer. I definitely, see what avenues are available there, and some are being very generous about what they're willing to do for their employees right now, especially if it was you lost your job of no fault of the employer or employee, just the circumstances. But go ahead and apply because you want to have your safety nets together, and it takes an amount of time for them to process all the stuff to get you on to the Healthy Indiana plan or other Medicaid plans that are available. So there's no reason to wait to just start getting that ball rolling.
I concur.
Are there any other resources that maybe we haven't talked about yet that people can access if they find themselves uninsured during this time? Are there any programs maybe specifically for like kids or for like young mothers or something like that?
Right, there's a specific program set for children. We alluded to it once or twice, the Children's Health Insurance Program. It's lesser known. It doesn't have as many billboards up sometimes as HIP. It's actually in Indiana, that and one for pregnant moms. It's under a bundle called Hoosier Healthwise. So if you see that and see some of the billboards, I think they redid their logo, so you'll get a little owl for the Who part of Hoosier. But that's a program that for kids, it's up to 200 and roughly 58% of the federal poverty level is the qualifying mark. So you're looking at almost double of the benchmark for getting on the HIP program because they really want to make sure kids are covered. And that's a program that sadly we're not seeing the same take up as we are with the Healthy Indiana Plan right now. So there's definitely a certain lack of awareness of that program and that's available to you. So Children's Health Insurance Program, also known as CHIP, where you can look under Hoosier Healthwise. And again, these are all available off the state websites as well, or something a navigator can help you with. I guarantee they know what you're talking about. But it's a really, really good chance if you're unemployed that your children are going to qualify for that. And that plan also does have some premiums attached to it depending on your income level, but just like HIP, they are frozen right now. So you're not going to have those additional costs. So and that's really concerning. I'm glad you brought it up because we really aren't seeing children's coverage being taken up through the state programs in the same way that we are seeing adult coverage. And again, it's probably just a lack of the information being out there publicly as well as it could be. That is available. We need our kids healthy right now. We need our kids immunized and vaccinated right now more than ever, especially as they're going back to school in either in a week or they're already there. We really want to stay on top of that, right? So that's a great coverage program and we want to make sure everybody's aware that that's in place and available for them.
And I will also say for those who may be transitioning from a place of incarceration to the public, the sheriffs and the correctional officers actually are able to do navigational type of services for folks who are transitioning. And so that's also another program that's in place that can be utilized to make sure that there is not a lapse in services as people are transitioning from an institutional setting back into the community. And then I'll also say, there's individual healthcare centers like Jane Pauley who have their own programs where they will provide healthcare services under a special plan. You can make payments and they will also submit an application process for you to the CHIP program as well as the marketplace if needed. So there's quite a few individual center programs that exist. It's about getting out in the community and just exploring what they are. Each center or health clinic may have some special nuances, but principally most of them are governed the same way.
We are getting close to out of time, which I cannot believe this hour flew by. But looking forward, how do you think the current health crisis will or could change health insurance coverage in the future? I mean, we've had people ask explicitly about Medicare for all. We've had people ask about if this is going to impact their premiums in the future. Do we have any idea, any projection at all of what could happen going forward?
Yeah, projections in healthcare is a dangerous game for sure. But we can say, the last time we faced a crisis like this was really back at the Great Recession about a decade ago. We had similar unemployment rates. It's actually the Healthy Indiana Plan was originally created around that. And again, before that we even had the Affordable Care Act. So at least as a state, we do have a history of reacting appropriately and seeing health coverage as a real immediate need. And we see the economic impact on hospitals and the state itself when people aren't healthy and aren't involved. So we'd like to think that messaging is slowly grinding in the right direction, that we're moving from the idea of healthcare coverage as something that you really should have to something closer to a right that everybody should have. So instead of, the logic of saying I should have it and I want it for myself, realizing that if we all have it, we're all healthier. If we all have it, we'd probably be able to cope with things like COVID a whole lot better. And we wouldn't have to be going through all the hoops we are now. We wouldn't have to have a discussion about how do we get hundreds of thousands of Hoosiers on healthcare coverage because they'd already be there, right? So I think some more eyes are going to open, definitely. And this is the kind of thing that's incremental. It's a society shift to realize the difference of something that's a good idea versus something that we absolutely need to have. But it'll be a move in the right direction. It's definitely, there's no space for it to be a backwards move. And especially the new conversations that we're really seeing that should have been there a long time ago about health disparities. Now that we're seeing them being so magnified by COVID, it's really putting those on the forefront to say, look, these aren't new disparities. These are the same disparities we've always had. Look how bad they are now that we can all see them just laid bare in front of us.
And I would just add that some of the things that has happened in terms of what is reimbursed and some of the activities such as telehealth or telemental health has been able to expand its services as a result of COVID. And so we would anticipate that some of the things that has happened during COVID will live past it, where telehealth, telemental health, and other types of services are still being maintained thereafter. Because right now, it's a lot of conditional provisions. And so we would hope that some of those things will be adopted as permanent practices on a go-forward basis. That what we find has really helped people tremendously in getting healthcare.
And we'll probably see a new disparity, sadly, emerge on telehealth access, because that's how that tends to go. So hopefully we're ahead of this one.
Calvin, sorry to put you on the spot here, but how or do you anticipate equity will be part of coverage and insurance conversations going forward?
Yeah, we believe it will, and it affects what we had talked about earlier with the HIP study, the continuum of the application process to the utilization of programs and services and how that's done, but also the process of how decisions are also made about things that are coming in. And so there are two things that's happening. There is the formal process itself, but then it's also the decision making that's attached to the process. And both of those things have to turn at the same time for it to really be operationalized. And so I think on a go-forward basis, the equity lens is going to look at those operational elements to really bring some parity in the healthcare system.
And with that, I think it's about time to wrap up. This hour, again, just flew by. Thank all three of you so much for being here and sharing your expertise. This has been really great.
Thank you.
Thank you for having us.
Yeah, our pleasure.
We're going to have a written recap of this conversation on the Side Effects website in the coming week or so. We'll be including links to many of the resources we talked about in that piece, so keep an eye out for that. Thank you to those in the audience who joined us today. If you have any questions that you would like us to look into, whether it's about coronavirus and its impact on our society or the healthcare system at large, or the upcoming 2020 presidential election, in which healthcare is going to be a big piece, we here at Side Effects want to hear from you. We use a text group called the Midwest Checkup to engage with our audience. That's how we got some of the questions for this panel and how we have some of the questions that inform our reporting. If you would like to be part of that group and kind of give us some input on what we should be looking at next, you can join the Midwest Checkup by taking your phone and texting the word HEALTH, HEALTH, to the number 73224. We would love to hear from you. And with that, I think it's a wrap. So again, thank our wonderful panelists for joining us today. Thank the audience for tuning in. Take care, and we will see you again soon.